So good morning, everyone. We have a dense topic to cover, but my focus will be on early breast cancer management. We'll start with an overview about hormone-positive breast cancer, our treatment approach, followed by neoadjuvant therapy, and then nuances about treatment of HER2 breast cancer and triple-negative breast cancer as well. So we'll start with hormone-positive breast cancer. As you can see in this slide, since the 1990s, we've started treating patients, since the 1970s actually, we've started treating patients with endocrine therapy, and this improved outcomes significantly. And you can see over the last few decades, the advancements in treatment in only hormone-positive breast cancer. In this slide, we're highlighting that tamoxifen improved breast cancer mortality. With 5 years of tamoxifen, we had a reduction of recurrence rates by almost 50%, which over 5 to 10 years reduced to about 30%. And in the following slide, we can see, in this picture beside it, where tamoxifen was compared to AI in postmenopausal women, we can see that AI had a reduction in recurrence rate when compared to tamoxifen. Traditionally, hormone-positive breast cancer is described as a well-behaving breast cancer. However, we do see that despite adequate management, that these patients still have a risk for distant recurrences. We see this even in the second decade after diagnosis. So there's an unmet need to further reduce the recurrence of invasive disease in these patients. In the next few slides, we'll highlight several studies that show that even the most early stage breast cancers, as you can see here, node-negative disease still had about 22% risk of recurrence at 20 years, and the highest being in the lymph node positive population with up to 52%, even 20 years after diagnoses. And over here in this slide, we can see that with hormone-positive breast cancer in the first few years, the risk of recurrence is less than ER-negative breast cancer. But as time passes on, you can see that the rate of hormone-positive breast cancer increases while the rate of recurrence for hormone-positive breast cancer decreases. Hormone-negative breast cancer decreases. So this is a real-world study that quantifies the risk of recurrence in patients based on their clinical pathological criteria. And we can see that in the 5-year IDFS rates, that the high-risk group, which is highlighted in the first infographic, had an IDFS of 92% compared to 90.9% in the node-negative group. So this corresponds to about 30% of patients in the high-risk group experiencing recurrence or death by 5 years, despite adequate therapy. Most patients in this group had received radiotherapy, chemotherapy. Approximately 11% had neoadjuvant approach of chemotherapy, and an aromatase inhibitor was prescribed in these patients, which can have a bit more benefit in high-risk patients compared to tamoxifen. So basically, we're highlighting that there is an unmet need for adjuvant systemic therapy for these patients with hormone-positive breast cancer who have a higher risk. And this slide, I just wanted to highlight that This may also be influenced by the fact that adherence to endocrine therapy is quite poor. With each year that a patient is compliant to endocrine therapy, we can see a 37% decrease in breast cancer deaths. So, who needs chemotherapy? We have several genomic assays which are validated to assess the risk of breast cancer recurrence and guide the use of chemotherapy in addition to endocrine therapy in these early stage hormone positive breast cancer. However, we still have challenges in identifying and targeting which subsets of patients are at high risk of recurrence or not. So in the next slide, I wanted to highlight that we have some retrospective validated signatures like the PAM50, the EndoPredict, and the Breast Cancer Index, which are the two in the middle and the third over there. And the NCCN recommends that they can be considered to help estimate risk of recurrence, but they have not been validated to predict the benefit of systemic therapy. At this time, the only prospective validated assay that is able to predict the benefit of systemic therapy is the Oncotype DX, and that's what we'll be talking about today. So the Oncotype DX recurrence score was validated through the Taylor X study for node-positive, hormone-positive breast cancer. So in this slide, I wanted to highlight the design where these patients were characterized into low recurrence score risk, 0 to 10. And these patients were given endocrine therapy based on previous studies that highlighted the benefit in this recurrence score group. And in high-risk group, highlighted in the green, with 26 to 100 recurrence score, they received endocrine therapy and chemotherapy. In the mid-range or intermediate group, these patients still, at this point, did not have information about which group benefits from endocrine therapy alone and endocrine therapy plus chemotherapy. And so they've been randomized to receive either endocrine therapy or endocrine therapy and chemotherapy, with the primary endpoint being IDFS. This was a non-inferiority design for the randomized arms. And the final analysis was done after 835 pre-specified IDFS events were reached. I wanted to highlight the characteristics of this intention to treat group, which showed that only a third of patients were less than 50 years. And as we know, the younger our patients are, the more aggressive the biology tends to be. So you can see that they are a bit underrepresented, especially the under 40 years group. And then we also have the tumor size, majority being between 1.1 to 2 centimeter. In this study, only 13% of patients actually had ovarian suppression on board, and postmenopausal women had aromatase inhibitor, 91% of patients. And the majority of the chemotherapy that was used was actually non-anthracycline based. It was taxane and cyclophosphamide. So basically, this study resulted in a non-inferiority. So endocrine therapy was not inferior to chemotherapy in the intention to treat population. As you can see in the infographic, there was less than 1% difference for almost all endpoints, which was IDFS, distance recurrence-free interval, and the overall survival. And the results were sustained at the 12-year mark. You can see that there was still, endocrine therapy was still not inferior to combination chemo and endocrine therapy. So on exploratory subgroup analyses, we can see that there was no statistically significant chemotherapy treatment interaction in these prognostic subgroups. So that means that regardless of tumor size, grade, menopausal status, and clinical risk category, there was a benefit of endocrine therapy similar to chemo and endocrine therapy. However, we can see that in the less than 50-year subgroup, there was a statistically significant chemotherapy treatment interaction with patient age and recurrence score. So you can see in the range of recurrence score between 16 to 20, there was a marginal benefit of 1.6%. And this increases to up to 6.5% with the recurrence score of 21 to 25. So this suggests that there might be benefit of chemotherapy in this group of patients who are less than 50 years of age, which is a premenopausal population in general. So in this slide, I wanted to highlight that when we stratify by recurrence score and clinical risk, in clinically low-risk patients from the range of 16 to 20, you can see that there was actually a benefit of endocrine therapy alone. However, with higher risk, clinical risk, which looked at tumor size and grade. Sorry. Can you hear me? Because we had a shutdown in our electricity for a second there. Can you hear me?
I can hear you. All is good.
Okay, great. I wanted to highlight that as the clinical risk increases, you can see that the benefit of chemotherapy in both ranges from 16 to 20 and 21 to 25 significantly increases from 6.5 up to almost 9%, which I wanted to highlight here in this infographic as well. I'm just going to see if I can get a pointer so I can show you on the screen. Pointer options visible. Okay, great. So so basically, if you have low clinical risk, there is still a marginal benefit for the patient, but with higher risk, you can see the increase in chemotherapy benefits. So it is still suggested for patients with chemotherapy in this group. So the Taylor-X study predicted that there was a chemotherapy benefit for patients in chemotherapy and endocrine therapy benefit in node-negative disease in that group. So in this study, we're basically highlighting whether node-positive, hormone-positive breast cancer also benefited from combination chemotherapy and endocrine therapy. So in this slide, we wanted to highlight the design, which included patients with hormone-positive breast cancer, lymph node involvement from 1 to 3, and were recommended to have adjuvant chemotherapy. If they had a recurrence score from 0 to 25, they were randomized to either a combination chemotherapy and endocrine therapy or endocrine therapy alone. As we know from the Taylor-X study and the previous validated studies, recurrence score of more than 25, we've already established that there is a benefit of chemotherapy in this group. And so these patients were automatically started on adjuvant chemotherapy in combination with endocrine therapy, and they were considered off study. So these patients were not followed. Only the patients with a recurrence score of 0 to 25 were followed. And the primary objective was to determine the effect of chemotherapy on invasive disease-free survival. And the primary hypothesis was that chemotherapy benefit will increase as the recurrence score increases. In the next slide, we see that there was a statistically significant chemotherapy treatment interaction with menopausal status and chemotherapy for invasive disease-free survival. So we were able to see that there was a marginal but statistically significant benefit in IDFS in women with 0 to 25, with an absolute benefit of approximately 1% in those who received chemotherapy with endocrine therapy. And this is better seen in patients who were premenopausal. There was actually no statistically significant benefit in patients who were postmenopausal, as highlighted in this slide here. In these forest plots, we can see that in premenopausal women, the benefit in IDFS was seen regardless of the subgroups. But it's worth mentioning that when looking at age, the younger the woman was, it seems that they had a greater benefit in chemotherapy. So in the most recent update, we were able to see that with longer follow-up, premenopausal women continued to have chemotherapy benefit, while postmenopausal women did not. This was not statistically significant. So what we conclude is that the RxPonder trial is able to reliably prognosticate risk of recurrence and helps us facilitate treatment optimization for postmenopausal women based on their recurrence score. And we were able to highlight that premenopausal women, if they were node negative, they were likely to have benefit from chemotherapy. So it was not predictive, but it is likely that they have benefit with treatment. But we were left with questions. Is the premenopausal subgroup likely to have more benefit because chemotherapy can induce amenorrhea? In the Taylor-X study and in the RxPonder study, unfortunately, our patients did not have ovarian function suppression as standard of care. So it's important to try and personalize this information for each patient and individualize it. So this brings us to the ongoing study called Offset Trial, which is going to try and highlight and see in this group of patients who are premenopausal and node negative with a recurrence score of 16 to 20 or 21 to 25, or the node positive group who are from 0 to 25. Do they derive benefit from chemotherapy and ovarian function suppression with endocrine therapy? Or is it enough to just treat them with ovarian function suppression and an aromatase inhibitor? So we're trying to highlight whether the benefit that they do achieve in IDFS is from amenorrhea or ovarian function suppression versus from the exposure to chemotherapy. So this is a highly anticipated study. So in summary, these genomic tests do provide prognostic information and help facilitate optimization for postmenopausal women and de-escalate therapy in this group who may not benefit from chemotherapy. So this brings us to our next section. Which chemotherapy treatment should we use? So before we go into the details of that, I wanted to first highlight how the landscape of chemotherapy has changed from first generation to third generation chemotherapy. In this slide, we have the NSAB-B23 study, which compares AC versus CMF in hormone-negative, node-negative breast cancer. CMF was the first combination adjuvant chemotherapy that was tested in prospective study in 1973. Patients at that time were given 12 cycles, and it was shown to have IDFS benefit. So in this study, CMF is compared to AC. And we can see that there was no difference in outcomes in patients who were treated with either CMF or AC. AC is usually given over 6 cycles, and in this study, both were given over 6 cycles. So this brings us to the second generation chemotherapy. where patients had concurrent administration of paclitaxel and doxorubicin in previous studies, it was shown that there was a substantial activity, but there was cardiotoxicity. So in this study, they wanted to see whether escalating doses of doxorubicin in combination with cyclophosphamide, given for 4 cycles every 3 weeks, is better as alone or with the addition of paclitaxel, which is that second generation combination. So we can see very clearly from these slides that the addition of paclitaxel was associated with an improvement in DFS. And at that time, that which was approximately in the early 2000s, that became standard of care. And we were able to see that escalation of doxorubicin dose had no impact of outcomes. So we were able to escalate the dose and decrease the risk of cardiotoxicity. Another combination that was tested was the combination of docetaxel and cyclophosphamide. So in the study, which is the US Oncology Research, they were able to evaluate whether patients who were operable and assigned to AC versus TC. AC is doxorubicin and cyclophosphamide, and the experimental drug combination was docetaxel and cyclophosphamide. So we were able to see over here that docetaxel was actually significantly improved in DFS compared to AC. So this was another combination that was available in at that time, which was the early 2000s. And this brings us to our current standard of care, which is the 3rd generation combination of chemotherapy. So it was found that the impact of dose density, which is giving chemotherapy every 2 weeks instead of every 3 weeks in the first caption, which is A, it was able to show that concurrent AC versus sequential AC, it was able to show that sequential AC followed by taxane, given in a dose-dense fashion, was more beneficial for IDFS. And then we were able to show that weekly taxane was more beneficial than Q3 weekly taxane as well. And another study was able to show that dose-dense taxane is similar in efficacy as weekly taxane. So this has now become standard of care, where we give sequential anthracycline-based chemotherapy followed by weekly taxanes. The next study is for us to determine whether anthracycline-based chemotherapy was equivalent to taxane-based chemotherapy. So this brings us to the ABC trial, where hormone-positive and hormone-negative breast cancers, which were node-positive or high-risk node-negative, were added on. And basically, the patients were either randomized to receive AC every 3 weeks, AC every 2 weeks, with a combination of taxane, or that's in the first arm, or concurrently, or in the second arm, docetaxel with cyclophosphamide without any anthracycline. So in the first arm, this was a joint planned efficacy analysis of 3 large randomized control studies compared to the TCs. So we were able to show through these forest plots in A, this was IDFS according to stratification, that there was a benefit of sequential AC with taxane, regardless of the subgroup. And this includes both hormone-positive and hormone-negative breast cancer. And in the second caption, it was a test for interaction by combined hormone receptor and nodal status. So we were able to see in hormone-positive breast cancer, with node-negative disease, that TC may be favorable for these patients who are less high risk. And then with patients with node-positive disease, we were able to see benefit with anthracycline-based chemotherapy. This is another large meta-analysis, which basically highlighted that the recurrence rates were 14% lower on average with taxane regimens, including anthracycline, compared to without. So you have studies that support anthracycline-based chemotherapy, and you have some studies that support in lower risk breast cancers the use of second generation, which is docetaxel with cyclophosphamide. This is just highlighting what we just talked about, which is that in the first half, where concurrent anthracycline-based chemotherapy compared to TC seemed to be equivalent. So, and in the second part, where sequential taxane and anthracycline was compared to TC, it seemed that there was no significant reduction in risk of recurrence. And less benefit was seen in this study with anthracycline-based chemotherapy, likely because it wasn't given as dose dense. So the next slide, we're just showing that adjuvant dose dense anthracycline-based chemotherapy followed by taxanes should not show any efficacy difference compared to concurrent anthracycline-based and taxane chemotherapy. It's usually not done because of increased cardiotoxicity when compared with other HER2, when added with HER2 targeted therapy. Basically, to summarize, in hormone-positive breast cancer, in those who have less or low-risk breast cancer, we can consider second-generation chemotherapy with TC, but with higher risk breast cancer, it's still recommended that these patients receive anthracycline-based chemotherapy given sequentially with taxanes. In high-risk breast cancer, it was shown that there was a role for CDK4/6 inhibitors in high-risk breast cancer to further reduce risk of recurrence. So we'll highlight this in the next few slides. So this is a slide summarizing the studies that looked at adjuvant CDK4/6 inhibitors, which is a targeted therapy given in the adjuvant setting and was also given in the metastatic setting. Basically, the first two studies, the Penelope B and Palace study, were shown to be negative. And it's not really understood why these agents were not effective in the adjuvant setting. However, the Monarch E study, which tested abemaciclib in combination with endocrine therapy compared to endocrine therapy alone, it was found to be a positive study. So we'll go into a bit into detail of that. So how it was studied was that patients who had a high-risk hormone-positive HER2 negative breast cancer, defined by their clinical pathological features in cohort 1 or by Ki-67 in cohort 2, as shown in the infographic there, were randomized to receive either abemaciclib in combination with endocrine therapy, or the standard of care at the time, which is endocrine therapy. And this was given at the discretion of the physician. So the primary endpoint was to test the superiority of abemaciclib plus endocrine therapy. And what they were able to find on primary analysis and with continued follow-up, that abemaciclib continued to show an incremental and consistently clinically meaningful benefit and statistically significant benefit in IDFS. As you can see in the Kaplan-Meier curves, that with time, the absolute benefit increased up to 7.6% compared to endocrine therapy alone, with a hazard ratio of 0.68. And this benefit was seen regardless of the Ki-67 status. But we can see in this study that the Ki-67 low population seemed to have, which is highlighted by the broken lines, they seem to have a better prognosis. So it was able to prognosticate, but not predict the benefit of a combination of abemaciclib with endocrine therapy. And this benefit in IDFS was regardless of ER expression. So that was a positive study. This was a study looking at ribociclib in combination of endocrine therapy. It's called the Natalie study. And as you can see here, they included both a low risk and a higher risk population and randomized them to ribociclib with endocrine therapy, which was anastrozole plus ovarian function suppression compared to endocrine therapy alone. And this study was recently presented in the San Antonio breast cancer conference or symposium in December. And they were able to show at the time of the data cutoff, which was approximately 27 months, that there was a small benefit that was statistically significant and clinically superior to endocrine therapy. So this was approximately 3.1% at the time. And this was regardless of the nodal status, the menopausal status, and Ki-67, which was similar to what we were seeing in the earlier follow-ups of monarch-E. So it'll be interesting to see with longer follow-up if this also incrementally increases and is sustained. And as you can see here, there was a notable difference in the absolute benefit from stage 2 to 3. We can see that stage 2 did remarkably better with IDFS of 94% compared to 92% with endocrine therapy alone. And in stage 3, this was lower at 88.1% versus 83.8%. And this is likely because it's a higher risk population. So what we were able to see is that both abemaciclib and ribociclib in the short term and intermediate term were able to improve IDFS, but longer follow-up is definitely needed to confirm the benefit. Overall survival for both studies is still immature. And in the ribociclib study, Natalie, only 20% had actually completed therapy. So there's still a large part of the population that's still receiving treatment. So as of now, only abemaciclib is FDA approved to be given for patients with high-risk breast cancer. What about the population of patients labeled as ER-low hormone-positive breast cancer? There's actually very limited studies on the benefit of endocrine therapy for these patients with an ER expression from 1 to 10%. We were able to see through this study that was presented in ESMO. This is a retrospective study looking at patients that were treated in Sweden from 2008 and 2020. So the international guidelines in 2010 lowered the cutoff for ER expression or ER positivity from 10% and higher down to 1% and higher. But in Sweden, these patients were still labeled as hormone positive at a threshold of 10%. So patients who had ER expression from 1 to 10% were actually treated similar to triple negative breast cancer with chemotherapy. And so in this study, we're able to describe real world patient and tumor characteristics. And as we can see here, It's basically highlighting for us that ER-low breast cancer behaves very similarly to triple-negative breast cancer. They tend to have a poor prognosis, but it's slightly better than triple-negative breast cancer. These patients tend to majority be grade 3 with a higher Ki-67. When treated with neoadjuvant chemotherapy, these patients had a PCR approximately of 28%. So slightly better than in triple-negative breast cancer, according to the Swedish trial. And only a very small majority of patients, a very small part of the population were treated with endocrine therapy. But most recently, this was spoken about at this St. Gallen. There was a consensus that these patients should also receive endocrine therapy. So we do treat them like triple-negative breast cancer, but once the chemotherapy portion of treatment is done, we do add on endocrine. We recommend the addition of endocrine therapy for these patients. So most recently at San Antonio, for this group of patients, they were looking into whether there was a benefit of adding on immunotherapy to chemotherapy based on the benefit that was seen in triple-negative breast cancer. So as we know, in the Keynote 522, we were able to see that the addition of pembrolizumab to neoadjuvant chemotherapy and then continued as adjuvant therapy after surgery resulted in an increase in PCR rate, and an event-free survival benefit was noted. In the I-SPY study, the portion that was hormone positive who received pembrolizumab and neoadjuvant chemotherapy, they seem to have a higher PCR rate as well from the addition of immunotherapy to chemotherapy. And so in the Keynote 756 study, where patients were confirmed to have a T3 to T4 node negative to N2 disease, or higher risk, so T1 to T2 with node positive disease, and were grade 3, so considered slightly more higher risk. These patients were randomized to receive neoadjuvant combination of immunotherapy and anthracycline-based taxane-based chemotherapy, followed by surgery, and then adjuvant pembrolizumab with endocrine therapy. And this study actually did include this ER-low population. So approximately 5% of our study population were considered ER-low. So we were able to see that there was a benefit of approximately 8.5% in PCR with the addition of pembrolizumab compared to just chemotherapy alone. The PCR rates aren't as high as the more aggressive subtypes, HER2 positive and triple negative breast cancer, where we do see a more robust PCR. However, this is a significant increase compared to what we usually see in ER-positive breast cancer. So we were able to note that the benefit was regardless of age, PD-L1 status, whether the patient received a dose-dense schedule in anthracycline or not, node positivity, and whether they are ER-low or just hormone positive. So this study actually suggests that the ER-low might actually get more benefit, which goes with what we know about tumors with higher proliferation. And this next slide, I just wanted to highlight that PCR rate was seen. So the PCR benefit was seen regardless of the ER status and PD-L1 expression. So this was considered a positive study. In the Checkmate 7FL, this is another type of immune checkpoint inhibitor that was studied, nivolumab, in addition to chemotherapy, with the same kind of concept where it was given neoadjuvantly in combination with chemotherapy, followed by surgery, and then continued with adjuvant therapy and endocrine therapy. So in this study, it was actually positive only in the PDL1 positive study. So they met their endpoint, but the statistical significance was seen in cells that were enriched with PDL1 and was increased in these patients as highlighted here. So what can we take from this is that there is encouraging data suggesting that higher risk hormone positive breast cancer will benefit from checkpoint inhibitors, but longer follow-up is definitely needed. In these studies, biomarkers were also being studied, and hopefully we'll get more information about patients who are higher risk, and we'll be able to predict who is likely to benefit and in which patients we're able to de-escalate therapy. Next, we'll move on to neoadjuvant therapy. So initially, neoadjuvant chemotherapy was used to convert patients from inoperable, locally advanced breast cancer to surgical candidates. Later on, this was used to convert these patients to breast conserving therapy with improvement in cosmesis, as was highlighted beautifully in our colleague Dr. Amiri's presentation. We were able to see our patients benefited from neoadjuvant chemotherapy similarly as when it was given adjuvantly. We were able to see through giving treatment neoadjuvantly that patients who actually received a PCR did significantly better, as highlighted in the infographic. They had a better event-free survival and overall survival compared to patients who had residual disease. And so this made PCR a surrogate endpoint for the efficacy of neoadjuvant chemotherapy. So you will see in these more aggressive tumor subtypes like HER2-positive breast cancer and triple-negative breast cancer that we tend to use for our higher risk early breast cancer patients, a neoadjuvant approach so that we can assess it's almost like a surrogate for whether these patients have a functional benefit, a biomarker of benefit in these patients. And we'll be highlighting that in the rest of our presentation. So in this study, I just wanted to highlight how our patients get a better outcome with PCR in all of our subtypes. So you have HER2-positive breast cancer, you have triple-negative breast cancer. This was more substantially seen in these more aggressive subtypes. So, as mentioned before, the use of PCR is as a functional biomarker. It basically shows us ways or new approaches to test the biology of these tumors so we know who we need to escalate therapy for and in whom we can de-escalate therapy. And as I mentioned, Dr. Al-Amiri highlighted this. We were able to also, through neoadjuvant approaches, lead to reduction in extent of axillary surgery by downstaging the disease that is in the lymph nodes. And then also, I think this will be highlighted later on in our radiotherapy sessions, how this benefits in reducing local regional extent of radiotherapy as well. So the future of neoadjuvant therapy is looking into the future direction is looking into de-escalation or omission even of local regional therapy based on response to these novel regimens. And hopefully with the addition of biomarkers, identifying who are the well behaviors that don't need aggressive local and systemic therapy. So this brings us to HER2-positive breast cancer. This is our current approach for these patients where small tumors, less than 2 centimeters, usually node negative, will go for upfront surgery. And then based on our findings, because as we know, about 30% of patients are found to have node positive disease, they may get further adjuvant anthracycline sequentially given with trastuzumab or anthracycline-free chemotherapy, or these patients can be de-escalated to a taxane plus Herceptin-based chemotherapy. So we'll go into the details today of the neoadjuvant approach, looking at what regimens were used neoadjuvantly, and then what do we do to escalate or salvage patients who have residual disease. We'll talk about future directions as well. So as we know, the addition of trastuzumab to adjuvant chemotherapy led to significant reduction in recurrence, about 50%, and survival improvement of about 30%. So these outcomes are excellent in this group of patients, which previously was thought to be quite aggressive. But we want to improve our outcomes for our high-risk patients, because as we know, even though we do have these improved outcomes, we have about 16 to 22% of patients that actually do have relapses. And with longer survival, we're seeing these patients coming back with brain metastases because the brain is thought to be a sanctuary site for HER2-positive breast cancer. And so we'll go into a bit of detail about the approaches for these patients. So in the next slide, I'm just highlighting that in the Neosphere study, we were able to show that the addition of pertuzumab or Perjeta, when it's added to a taxane-based therapy with trastuzumab, we were able to see about an increase in PCR. And in the next slide, we were able to see that whether the chemotherapy backbone is anthracycline-based or just taxane-based, we see this improvement in PCR regardless. And the outcome was consistent across all levels, whether it was a smaller tumor, node negative, or positive, hormone positive, or hormone negative. So basically, whether you use an anthracycline-based or a taxane-based chemotherapy regimen with dual HER2 blockade, you're able to see similar PCR and improved long-term outcomes with the PCR. And so we're able to spare patients the cardiotoxicity of anthracycline in this group of patients. What are we looking at now is, can we forego chemotherapy altogether with antibody drug conjugate TDXD, or do we need to give it in addition to some chemotherapy, so taxane-based chemotherapy, or do we stick to anthracycline-based chemotherapy in addition to dual blockade? So this is an ongoing study called the Destiny Breast 11 study, and we're hoping to get results of this soon. So what do we do for patients who have residual disease? We briefly mentioned antibody drug conjugates in the previous study. What are these group of drugs? It's basically a monoclonal antibody that's covalently bound to a cytotoxic agent via synthetic linkers. So it's able to carry a cytotoxic payload, and once the agent or the antibody drug conjugate binds to the cancer cells that are expressing the antigen of choice, it leads to cell apoptosis and minimizes toxicity in this patient. So this revolutionized cancer care in HER2 positive breast cancer, in the metastatic setting, in triple negative breast cancer, in the metastatic setting, and also in HER2 low in HER2 low cancers that are HER2 negative. So in the adjuvant setting, we use the antibody drug conjugate called TDM1, which has an entansine payload, which consists of maytansine and a microtubule inhibitor. Basically, this carries a payload to antibody ratio of 3.5. So it carries approximately 3.5 molecules of the payload attached to each antibody. So we were able to see through the Catherine trial, where patients had neoadjuvant chemotherapy along with HER2 targeted therapy, and dual blockade was allowed. For those who did not achieve PCR, they were randomized either to get this experimental drug at that time, which is now FDA approved, TDM1 versus trastuzumab, which was standard of care at the time. And basically, we were able to show on primary analysis of an absolute benefit of 11% in IDFS. And we can see with time, this was sustained and increased to about 13.7% by 7 years. And you can see that with time, patients who get trastuzumab alone, their outcome was worse. So overall survival is still immature, was still immature at the primary analysis, but most recently, in this slide, I just wanted to highlight that the first that the first occurrence of an IDFS was a distant recurrence, and of those, it was about 5% CNS involvement, and it was similar between the TDM1 and the trastuzumab group. So the brain is still a sanctuary site for these HER2 positive breast cancers who receive antibody drug conjugate TDM1. So it was still considered an unmet need that we're unable to prevent brain recurrences. I just wanted to highlight, I don't have the slide here, but in the most recent update, there was actually an overall survival benefit with the addition of TDM1 as a salvage therapy. In the next slide, I just wanted to highlight that immunotherapy, when added to a anthracycline-based chemotherapy, did not improve PCR when compared to chemotherapy alone. And longer follow-up may inform if there is any survival benefit. So what are the studies that are currently ongoing in this field? As we said, CNS is usually a first site of occurrence. These patients tend to do quite poorly. And so we're looking at studies now we're looking at agents now that have been shown in the metastatic setting to have had some benefit in the CNS. So these agents are tucatinib and TDXD. And we can see, just for the sake of time, I'm going to skip this pharmacology slide, but I just wanted to show that TDXD, which was found to have excellent results in HER2 positive breast cancer, is now brought in the neoadjuvant setting, where TDXD in the adjuvant setting, where TDXD is given as a salvage therapy or TDM1 for these patients with residual disease. And we're really anticipating the results of this because they're also doing a biomarker analysis to help us identify who needs an escalated approach. And then you have the COMPASS-HER2 study, which again is looking at trying to de-escalate therapy in patients who achieve PCR. But in those who do not achieve PCR, is there a role for addition of tucatinib to salvage therapy TDM1 versus TDM alone? So we're really anticipating the results of these studies, which could show us that because of their CNS penetration, they may prevent or lower risk of breast cancer recurrences in the brain. So I'm going to skip the slides about de-escalation strategies. But we basically wanted to look into what the future direction is for hormone or HER2 positive breast cancer. We really need to identify who needs escalation and who needs de-escalation so that we are able to, in this precision medicine era, personalize therapy for these patients and prevent over-treatment. In triple-negative breast cancer, which is also considered an aggressive subtype of breast cancer, prognosis a few years ago was quite poor. And we can see that in 2024, we've added on immune checkpoint inhibitor and other targeted therapies, which have improved outcomes. So I'll be highlighting the patients who have tumors that are 2 centimeters or higher. And basically what I wanted to highlight is that we were able to find a significant benefit of adding on immune checkpoint inhibitors to anthracycline and carboplatin-based chemotherapy. So in this study, the KEYNOTE-522, we were able to see that with the addition of pembrolizumab to anthracycline-based, carboplatin-based, and taxane-based chemotherapy, a benefit in PCR from 51 to 64.8%. And this was regardless of disease stage. We were able to see that patients who had lymph node negative disease did slightly better, but node positivity and PD-L1 status was not predictive of benefit of pembrolizumab in addition to this chemotherapy backbone. In fact, all of these subgroups actually did well. We were able to see with longer follow-up that this corresponded to an event-free survival benefit at the 4th interim analysis. And you can see this was statistically significant, and it was seen across all pre-specified subgroups. In this slide, I wanted to highlight that these patients, if they achieved PCR, had a better prognosis. But in those who had residual disease, we still saw an EFS benefit. So it's still recommended at this point that we continue on the immunotherapy if we do see a PCR as well. When atezolizumab, another immune checkpoint inhibitor, was tested, unfortunately, this was not a statistically significant study. We are now looking at de-escalation of anthracycline. So we were able to see through this smaller study called Neoadjuvant. It's a phase 2 small study, which was able to show that we may be able to, in future, de-escalate chemotherapy backbone for our patients so that we can avoid some toxicity. But of course, a larger perspective study is needed to finalize our conclusions. So just for the sake of time, I just wanted to highlight basically for our group of patients that we're talking about, the high-risk breast cancer group, we are still looking at how to identify who needs escalation of therapy and who needs de-escalation of therapy. We're looking at the role of adjuvant, we're looking at the role of chemotherapy-free regimens and possibly omitting chemotherapy completely from the treatment regimens, both neoadjuvantly and adjuvantly. And we're highly anticipating the results of these studies.